Next point is, how does the cerebellum do its job? Well, we already know that the Purkinje cells are the most important neuron in the cerebellar cortex, and they are receiving either direct or indirect excitatory input from all the contracting muscles, the motor plan, and the vestibular system by way of either climbing fibers or parallel fibers of granule cells. We know that the Purkinje cells are inhibitory, they project out, and they modulate by inhibition the activity of the deep cerebellar nuclei in a topographically organized fashion. And as we've indicated, the topographic organization has the vermis linked to the fastigial nuclei, intermediate hemisphere Purkinje cells linked to the interposed nuclei, and lateral hemisphere Purkinje cells linked to the dentate nucleus. So in terms of circuitry, the goal of the cerebellar outflow, mediated by axons of the deep cerebellar nuclei, is to influence the firing of upper motor neurons. Because the cerebellum, since it influences upper motor neurons, indirectly it's going to, by these pathways, modulate or smooth out the series of skeletal muscle contractions generated by the lower motor neurons on the other side of the motor pathway. But here's the point about how the cerebellum really works and where one side of the cerebellum mediates its effects. So in our example here, we're showing again a picture of the cerebellar cortex in the middle of the slide, and we've arbitrarily divided into a right and a left half of the cerebellar cortex. So all we're going to talk about by way of illustration here is where do we find the upper motor neurons that are being driven by the right half of the cerebellum. So the right half of the cerebellum, of the cerebellar cortex, sends its Purkinje cells out to various deep nuclei on the right side, as indicated here. And the axons of those deep nuclei leave the cerebellum in the superior cerebellar peduncle. But the interesting thing about those deep cerebellar nuclei axons, once they descend down in the midbrain, they all cross the midline of the brainstem in the midbrain. And some of those deep nuclei axons influence a minor upper motor neuron system in the red nucleus known as the rubrospinal tract, but the major destination, particularly of the lateral hemisphere of the cerebellum, is to influence upper motor neurons in motor cortex that give rise to the corticospinal tract. So the axons coming out of the dentate nucleus cross the midline in the midbrain, and their goal in life is to reach and influence upper motor neurons. But as we know, no neural system can reach and influence a cortical neuron without a thalamic relay. So the dentate nucleus crossed axons must synapse first and relay through a series of what we call the motor nuclei of the thalamus. And the two motor nuclei are VL, ventrolateral, and VA, ventral anterior nuclei of the thalamus. And from there, those thalamic nuclei project to motor cortex, influence the firing of upper motor neurons at their cellular location. But the interesting thing is, as we know, the axons of the corticospinal tract cross on their way down to influence lower motor neurons in the spinal cord. So, as a result, the net effect is that since the cerebellar outflow crosses, but the corticospinal tract also crosses, the net effect is an ipsilateral one, meaning that the right half of the cerebellum is going to promote the smooth execution of skeletal muscle contractions on the right side of the body, because the outflow of the cerebellum crosses, influencing upper motor neurons, but the axons of the upper motor neurons also cross. So it's a net ipsilateral relationship, meaning clinically that if I have a problem just on one side of the cerebellum, for example, the right, the patient is going to tend to fall or lose their balance or lack fine-tuning of skeletal muscles that are ipsilateral to the lesioned cerebellar hemisphere. So, in summary, we can see that various regions of the cerebellum project out to specific deep cerebellar nuclei, and their goal in life is to influence various populations of upper motor neurons. We know that we have upper motor neurons that are arising from the vestibular nuclei associated with anti-gravity muscles. we have upper motor neurons that we just illustrated that are playing less important roles that are arising from the red nucleus and even from the reticular formation. But as we know on the next picture, arguably the most important of the cerebellar connections is one that involves the lateral cerebellar hemispheres, the dentate nucleus, relays through the thalamus, and influences the corticospinal tract neurons, which basically help smooth out the execution, particularly of limb muscles, by influencing the lower motor neurons that perform those tasks. So, what do we see in a patient that has a cerebellar lesion? Well, we're not going to see a patient that has any weakness or paralysis because the lesion is to a motor control center and not directly to either the upper or the lower motor neurons. But what we do see in a patient with cerebellar disease is a tremor with the intended movement because based on the lesion location, you will lose the fine-tuning or the coordination component of a series of skeletal muscle contractions. So a hallmark of cerebellar dysfunction is just that, a tremor with the intended movement without weakness or paralysis. And again, as we've already indicated, if we have a unilateral or one-sided cerebellar lesion, the effects of that lesion will be expressed ipsilaterally, because as we've just seen, the deep cerebellar nuclei axons that leave the cerebellum cross, they influence motor cortex, but then the corticospinal tract fibers basically cross on their way back. Next, we need to be specific about the differences in a vermal lesion of the cerebellum versus one that involves the cerebellar hemispheres. As we know, vermal lesions are going to largely affect either trunk musculature, axial musculature, or muscles controlled by the intermediate hemisphere, which are proximal limb muscles. So it's unlikely that we'd see any manifest associated with problems in our muscles, but the classic signs associated with a vermis lesion affect the proximal muscles in the lower limbs. These are thigh muscles that play a major role in gait. So kind of a hallmark of a vermis lesion is an ataxic or a motor generated ataxic gait that is associated with vermal neurons. But recognize that this ataxic gait is going to be different from the ataxic gait that we saw in a lesion of the dorsal columns. So we kind of make the distinction that a vermis lesion of the cerebellum produces motor ataxia, whereas a lesion of the dorsal columns, as we saw in spinal cord, produces a sensory ataxia. And another way to distinguish them, because the gait will fundamentally look the same if it's a complete vermis lesion, patients with vermal damage will not have a Romberg sign, because a Romberg sign is generated when you lesion the sensory input to the cerebellum, in part carried by the dorsal columns, and a Romberg sign, as we know, occurs when the patient sways back and forth only with their eyes closed. But a patient with vermis damage is going to sway with their eyes open or closed because the lesion cerebellum cannot help you maintain balance using visual input. So the other thing that's important about the vermis is we need to distinguish anterior vermis neurology from posterior vermis. The anterior vermis is a classic location. If a lesion is located, they'll present with a motor ataxia. But it turns out that anterior vermis Purkinje cells are particularly sensitive to chronic alcohol abuse that leads to a motor ataxia. In contrast, posterior vermis lesions are more likely to affect trunk muscles and cause what is known as a truncal ataxia, where the patient has difficulty maintaining an upright sitting position on a bed or a table. But unlike the anterior vermis, which is affected by chronic alcohol abuse, posterior vermis lesions much more likely result from different forms of cerebellar-based tumors, either medulloblastomas or ependymomas. This slide illustrates some of the features that distinguish a cerebellar hemisphere lesion from a cerebellar vermis lesion. Once we move out into the hemisphere, we're involving control of distal musculature and the dysfunctions associated with that. So this is where we see some of the classic signs of cerebellar disease, usually in the form of a tremor with the intended movement. So when the cerebellar hemisphere is involved, the intention tremor basically is evident as a motor task is being performed, and the tremor of the limb will increase as a target is approached. And certainly, since this is only a tremor with the intended movement, basically the tremor will be absent or barely noticeable when a patient is not attempting to perform a motor task. A couple other things. One is, what is dysmetria? Dysmetria literally means difficulty measuring. So the patient has a disability or a problem stopping a limb at the proper place. So they'll classically have problems performing the finger-to-nose test, where you ask a cerebellar lesion patient to abduct their arm to the shoulder and touch and basically perform a series of movements of the upper limb, asking the patient to touch their finger to your finger and then to their nose. Patients with cerebellar disease will have difficult time stopping their limb at the proper place, and obviously they'll have the intention tremor laid over the intended movement. Next, one of my favorite words in clinical neurology is, what is a patient's problem when they have a cerebellar hemisphere lesion that results in dysdiadochokinesis? That's a reduced ability to perform what are known as rapidly alternating movements, like pronating and supinating the forearm and slapping the anterior thigh in between the movements. Patients with cerebellar disease will certainly have a difficult time performing that series of coordinated activities smoothly. Next, patients that have cerebellar disease may have speech problems. They won't have an aphasia, but they will speak in complete sentences, but they will break up the individual words into the component syllables, so they'll have more like a staccatic speech, disrupting its melody. Patients with cerebellar disease are also likely to have gaze problems. As we've already seen, the cerebellum doesn't actually generate gaze because it's not a gaze control center. It helps keep your eyes fixed on a target once it is located, such that patients with cerebellar disease will be able to generate a horizontal saccade to locate a target, but without the cerebellar control, the eyes will tend to drift off the target, requiring an individual to regenerate a horizontal gaze command to relocate the target in space. And finally, if a cerebellar hemisphere lesion includes not just the cerebellar cortex, but also the deep cerebellar nuclei, the patient is likely to present with suppressed muscle stretch reflexes. And this is simply just a reminder that having suppressed muscle stretch reflexes is not always exclusively associated with a lower motor neuron lesion and a flaccid paralysis. Patients with cerebellar disease, obviously involving the deep cerebellar nuclei, may also have reduced muscle stretch reflexes, but certainly they're not going to have any weakness because it's the cerebellar deep nuclei that are involved and not the lower motor neurons.